And thank you everybody for listening to this small discussion. So I'm going to talk about multimodality imaging in cardiac cases. These are select cases. So this is case number one. So the vignette is a little bit longer. I promise the next one is not going to be that long. So 53 years old man with past medical history of hypertension, hyperlipidemia, diabetes, CKD stage 3, and recently diagnosed carcinoid tumor. It was a small intestine neuroendocrine tumor. He had surgical resection, and the pathology showed 2 centimeter unifocal, well-differentiated neuroendocrine tumor invading visceral peritoneum. Patient had PET CT using gallium that showed intense pathologic uptake and the mesenteric mass, most consistent with neuroendocrine tumor, and this is post-surgical. Case was revisited with surgeon. Surgeon said he's not able to do any further surgery at this time, and he didn't offer him surgery. But because the PET showed like a focus with cardiac uptake, patient was referred to cardiology. In the meantime, due to diarrhea and positive 24 hours urine for 5-HIAA, lanreotide was started, and patients had slight improvement in the first few weeks. So this is the PET CT. These are the pictures on the left are for the coronal sections. So these are coronal cuts. And as you can see, this is the high, I'm gonna stop it here, but this is basically the high intense, sorry. These are the high intense mass in the abdomen. Okay, as you guys can see here, and I'll direct your attention as well next to this area here that's hot and the anterior wall of the myocardium. Okay, and this is the axial stack starting from the head. I'm just going to speed it up a little bit here, and as you can see here, it's very hot area in the myocardium, and again in the anterior wall, very close to the septum. Okay. So this is the echo, parasternal long axis view, normal function, maybe a little bit of calcifications and the base of the mitral anterior leaflet slash aortic annulus, but nothing major. So this is contrast echo, shows us normal wall motion. This is for chamber view, again, normal wall motion. Parasternal long axis view with contrast this time, again, normal wall motion. So patient was sent for CMR to further investigate this mass, 2 chamber views, anterior and inferior wall, and 3 chamber views. Again, normal wall motion, 4 chamber view, normal wall motion. If you guys don't see anything unusual here, I'll direct your attention to this area here. So this is the anterior wall, this is mid to distal. So see this, we do our cine images in our lab after giving the contrast. So as you can see, there is something that's lighting up here. So these are perfusion images. So the mass is here. So as you can see, so there is normal perfusion in the left ventricle, and the mass as well gets some of the contrast. So this is short axis stack of the late gadolinium enhancement pictures, and I'm going to direct your attention to the same area, which is here. So this area has GAD already, and the late GAD images, which is significant for basically myocardial scar. So this area diameter actually was small. So the title of this case is Never Too Small to Image. This is the short axis cine views, and this is the mass that you see here. This is the late gadolinium enhancement pictures. As you can see, it's all scarred. This is the T2 and T1 mapping. So T1 mapping, the area is intense. T2 mapping, area is intense. And remember, these are both before giving the contrast. So follow-up, patient felt better after lanreotide administration, and then the PET CT scan in 6 months showed similar cardiac findings. So the lanreotide did not affect the cardiac finding, and the abdominal mass was exactly the same, but symptoms was better. The take-home points are primary carcinoid tumors, metastasis to the left ventricle is very rare, as we all know, especially when it comes to the small intestine. It typically affects the right side valves and right side heart first, not the left side usually. But this is a very rare occurrence. Cardiac MRI protocoling is essential, right? Because see how where the mass is and how small it is. Sometimes regular protocols may miss it. And the last item is multimodality is a key. So without me looking at the PET scan beforehand, protocoling the study would have been a little bit difficult if I just use the routine protocol. We published this case already if anybody wants more information on it, and I'm open for questions.